Can I ask all the speakers to just comment on why it is, do you think SDF has not been widely used as much as it should be done in community programs? We have large numbers of community programs, caries prevention programs, but SDF is still, I suppose, not on the top of the list for people to introduce. Do you feel it's because the research is still emerging, or do you think there are other reasons? Rick, what do you think?
In the US, concretely, the payment system is not caught up with the clinical knowledge. We do not incent in the US for prevention, we incent for intervention. And we have a 100-year-old industry doing exactly that. So in New York, we don't get reimbursed for doing silver diamine fluoride. In fact, for fluoride varnish in New York State, you only get reimbursed for fluoride varnish for kids up through age 6, not for children over that. So that's a disincentive. In New York, I think it's $30, $35 for a prophy, which has no impact on caries. So the incentives are totally awry, financial incentives. I think if clinicians got paid for prevention and for health, we'd have a different approach or a different behavioral approach by clinicians.
Okay, well, thank you. CH, in your experience, this widespread kindergarten provision, has that translated? Do general practitioners now are embracing SDF more in Hong Kong?
Yes, we are promoting, but I would say professionals sometimes will not take up a new strategy very quickly. So going back to my first study, actually is 2004. And you see how many years it takes before it's widely recommended, even in the United States. It's more than 10 years. So I think it is more important to share more information through different channels to let the, our colleagues to know that there is a new strategy for the caries management. I think that is important. When we want to talk about the effect of these products, I think it's again very, very important that to make sure that caries prevention is a holistic approach. It's not just the SDF. Otherwise, it may backfire the effectiveness of the SDF. That is, I think, the key message I want to share. It's a very powerful caries arresting agent. And it's also a very powerful anti-hypersensitivity agent. So that's why I think it is very indicated, it's very appropriate to use on young children. This is non-invasive, painless, simple technique that can stop the pain, reduce the sensitivity, and arrest the tooth decay.
Very good, thank you. Prateep, your experience in Thailand, are general practitioners using SDF? I know the community programs do embrace it, but is this being translated into clinical care at the practice level?
Right. I think SDF is for the community is very clear because it can approach many students, many people at the same time. For the general practitioner, as Professor Chu mentioned, we need more information from everywhere. Recently, I just read the FBI policy in this year, just last month in San Francisco. They also mentioned that SDF is one of the options that should be considered for the general practitioner, the dental school, and the public health to be used. And a message like that, I think, is very powerful for the dental association to take away and for the dental school and to teach more in this area. And it's, as Chu mentioned, Professor Chu mentioned, I think it takes time, but I think it will be in the mainstream and not so far, I think.
Okay, thank you. Jeff, in Australia, your experience of general dental practitioners using SDF?
Well, SDF virtue was first used in Australia by Graham Craig, came back and did a PhD in the 70s. And it was just starting to get legs. It was being used in the West Australian Public Health Service. And then this paper was published suggesting it might cause fluorosis, and that just shut the whole thing down for a number of years. And it's gradually coming back again, and there's interest in it. But I think certainly that the point that Rick made is that there's no remuneration for it. Dentists are very loath to sort of provide the service. There's the health funds certainly have a large input on the fees that dentists charge. There's a lot of corporatization going on, and that's an issue as well. And the other interesting thing I found, but I was going up to Timor-Leste with a group, and I bought some silver diamine fluoride with me. I was painting around. There was a bit of interest, but nobody was really sort of taking any notice. And it wasn't until the next year that went up there, and they were saying, "Look, we've got these strange sort of teeth. There's these huge lesions, but they've gone black and they've gone very hard." And we were putting glass ornament cement over the top, but of course the glass ornament was washing off. I think even if it's only there for a short period of time. So it's a combination, I think, of the dentists really don't. It's slow to take off about. You can talk about the benefits, but you need to see the benefits, and therefore they're slow to take on the new technology, particularly when they've been trained in a particular way. Because dentists are told when you leave dental school, you do this, you don't even think about doing anything else. And also, I think it's the constraint that dentists don't think they're going to get remunerated for providing the service.
Okay, thank you. There's a question somebody's asked with regard to deep cavities and any concerns you would have about a cavity being close to the pulp and applying SDF. Petit, would you have any concerns if there was a deep cavity and you think there may be close to the pulp?
As you may know that recently there is a group of the international caries remover consensus meeting that they said that if there is a deep cavity, and so far if it's not yet exposed pulp, it still be it still be good that the pulp is still vital and can respond well. So in that case, I think that so far I think the SDF can still be applied to that area, because SDF is good for the for remove bacteria in that area, and also the fluoride in that area can enhance the remineralization behind that. I don't think that there will be any effect to the pulp so far, but we need evidence in that case. But I think maybe Professor Chu can mention more on that one. But to my experience, when it's a deep cavity, we still use the SDF to paint on it before we put on the glass on top of that one. We're still using that as well.
Okay, I do. CH, in Hong Kong, if you have large cavities, was there any protocols with regard to the placement of SDF?
Actually, it's very difficult to judge what is deep, what is not deep. So basically, in our kindergarten, we just apply SDF to those dentin decay. So for enamel, actually, we do put SDF in most of, if not all, the SDF. If the children are cooperative, then our survey found that there's no significant increase in the complication among the children. That's what we found. And actually, this is published in the JDL. Then, anyone who are interested can log on to go into the details of the different types of complication. And we do not find that significant increase of the complication after SDF application.
Okay, I agree. Rick, there's a question here about do your nurses, your therapists, does a dentist determine the diagnosis, which teeth should receive the SDF, or do the nurses make that decision when they examine the child?
We have a blanket approval. So a nurse under indirect supervision and indirect approval of the dentist, because we have to have a supervising dentist or a physician, or interestingly in New York, a podiatrist. So talk about non sequiturs. A podiatrist in New York can approve a nurse or a hygienist applying silver diamine fluoride. So the nurses and the hygienist are doing the assessments of whether there's a carious lesion and applying fluoride varnish. In New Hampshire and Massachusetts, no dentists are involved in doing the assessment of whether there's caries.
Okay, thank you. Okay, thank you. I'm going to give each one of the speakers just a few minutes to do a take-home message. What would be the take-home message you would give to this global community about SDF and community programs? Prateep, I'm going to start with you. What would be your take-home message from this webinar?
I would like to propose that the SDF is a good option for the community, especially in the community where there's a high prevalence of caries, both in the early childhood caries in the preschool children, as well as in the root caries in elderly. It is practical and easy to apply. And I think this is the way that we will changing the attitude of the people to the dentistry, that this can be what we call no pain dentistry, and it have a good power and very powerful for the prevention as well as a part of restoration as well. So we can apply SDF in both of the secondary prevention and tertiary prevention, depend on the caries and size of the caries and the management of the caries, and that we have and that we will find in the future. So I think that the SDF is one of the options that is very practical and maybe affordable, and also maybe acceptable for everybody in the future. Thank you.
Thank you. CH, what would be your take-home messages for the dental community?
From our own experience, I would say first, use 38% SDF even though you are managing very young children. Don't use 12%. This is the first. The second is SDF is a very effective agent, but that need to be complemented with good oral hygiene and also a control of the carcinogenic diet. This is the second point that I think it is important for the children and the parents to know. And finally, from our experience, is parents and also children acceptance is extremely high if you get them well informed of the benefit and the complication of the treatment. That is the key points that I want to share.
Thank you. Rick, what would be your take-home messages?
Mine are three, actually one. It goes from 3 to 1. SDF meets healthcare's triple aim. That is that it significantly improves health, it's high quality, and it reduces costs.
Very distinct, thank you. Jeff, take-home messages?
Yeah, thank you, Rowan. Well, my experience is that it's much slower to be taken up amongst private dentists as it is in the health system. Community, the public health system, where there's budgets and an overwhelming number of patients to treat. SDF will integrate into this system really successfully. And if the public health system take it up and do across the board protocol, as I said before, of making sure that people don't need to leave the emergency clinic with any active caries, of ability to reduce GAs in small children. This idea will gradually become it'll save the government coffers a lot of money, but to seeing it done so successfully in the public system will then sort of bring it into the private system and see it done as a standard treatment of care, because I think the pharmacological management of caries is certainly the way that we should be all going.
Good, thank you. Well, my role as chair is to summarize some of the take-home messages. For me, this has been an important webinar. I think the place for traditional school-based programs where mobile units are taken and traditional care is placed in schools really is outdated. And I think the work coming from New York is showing us clearly that there should be a radically new approach to community-based school programs. I think Hong Kong has taught us that silver diamine fluoride, whether we call it the magic solution, a dental vaccination, has the ability to attract community support. And in Hong Kong, we've seen from politicians to funding agencies to rally round that when the benefits are seen, that they want to do this across the whole of the island. It also has the ability to attract irregular users or people who don't traditionally take their children to the dentist, of very young children. And so SDF has an effect to actually bring those people to a pathway of a dental home. I think also the silver ART is a very attractive proposition and has now really succeeded or supplemented the traditional ART approach. And I think silver ART, which should get a lot more attention and research and some of the clinical findings. But I think, Jeff, you raised in Australia this radical reduction or an almost elimination of general anesthetic of young children who have dental extractions or treatment. Stopping the decay young and reducing pain and sepsis is, I think, one of the things that's going to attract a lot more attention for SDF. We haven't tackled the clinical situations, but there are lots of situations where, whether you're in the public sector or the private sector, dealing with fragile senior people, people with dementia, people with in hospitals with chronic illnesses, any situation where caries management has to be done simply and just by resting rather than the traditional restorative approach, SDF has got to be one of the frontline procedures that we have in dentistry. I'm sure there's many other things to be said, but at this stage, I'm drawing this webinar to a close and want to thank a number of people. First of all, I want to thank our speakers, who some have got up very early in the morning and some have stayed very late at night. So I want to say thank you very much for this stimulating conversation. I also want to thank the sponsors of the University of Geneva, the Global Child Dental Fund, and Colgate-Palmolive. This has grown. We had a limit of 500 people who could register for this webinar, and we have exceeded that already. So there is a growing attention and a growing interest in silver diamine fluoride. And I'm sure this will just be the first of many seminars and webinars that will look at different aspects of dental care for different types of population. So thank you all very much. I draw your attention to next slide, please, that we have a webinar in next week, which will be talking about daily toothbrushing in schools from a number of different parts of the world. And then on the 15th of November, we have a discussion about the importance of integrating general and oral health. In 2020, we will announce a whole series of new webinars. But again, thank you all very much again. Thank you for all who participated. Thank you for the team in Geneva and all who've done the logistics for this webinar. And so with that, I call this webinar to a close. Thank you all again very much. Bye-bye.